Which is highly appropriate since I'm the one who suggested that he come to speak here. I should give you the background how I met him. I've been looking for an ENT specialist for my entire career, and Joy Moeller told me that I needed to meet him, and I told him that he needed to meet me. So we connected, and he came out to my office. And I knew his credentials. I knew that he'd gone to Harvard Medical School. I knew he wasn't a dummy. He went to UCLA for his ENT, then he went to Stanford for sleep, and that's about as good a pedigree as you could ever have. But I'm not the one to be impressed by pedigrees. The results are what matters to me. So when we met, I pushed him pretty hard on some things, and he reacted in a perfect way. He is a very humble guy, super smart. I don't know how people that age can be that smart, actually, but he's done more research in his young life than most people ever do in a lifetime. And it's literally changed my life. I write referrals to him all the time. I couldn't practice without him, and I'm telling you, he's going to change the way you practice. Dr. Soroush Zaghi.
Thank you so much, Bill, for that incredible introduction, for setting up such a great example this morning on the importance of sleep and breathing and different things we can do to prevent these issues. My name is Soroush Zaghi. I'm an ENT sleep apnea surgeon. I went to Harvard Medical School. I did my residency at UCLA and I trained to be a Stanford sleep surgeon. And I'm quite honored to be here with you at the Academy of I'd like to thank Dr. Lipskis, Dr. Holmes, as well as all the diplomats, associates here for inviting me to come and talk to you guys about the importance of tongue-tie and myofascial dysfunction as a phenotype for craniofacial pain. And so I am currently functioning as a medical director of the Brain Institute, and so those are listed. I trained as a Stanford sleep surgeon. So when I went to Stanford after completing ENT residency, I learned to take a multidisciplinary approach to the treatment of sleep apnea. I was trained in sleep medicine, ENT, sleep dentistry, myofunctional sciences, as well as maxillofacial surgery. And we learned to take a clinical research and evidence-based approach. And this shows you just a few of the publications that we worked together just in 2016 and 2017. And since that time, I've been working out of the Breathe Institute to treat patients with a structural and functional approach for pediatric and adult sleep and breathing issues. We focus on patient care, research, and education. So when I was in fellowship, the be-all and end-all for sleep apnea that we learned about was the maxillary mandibular advancement surgery. And we learned from Bill this morning the importance of fixing things in the anterior, posterior dimension, and can't reinforce enough how important that is. And so I was supposed to author this paper that looked at all the studies that were done to treat sleep apnea with maxillary mandibular advancement surgery, and we showed that it significantly opens up the airway, like you can see in this photo, and reduces the severity of sleep apnea by 65 to 80%, which is really incredible. And if you look at the overall surgical success rate, which is indicated as a 50% reduction to levels below 15 events per hour, that's 85.5% of patients had a successful outcome by moving their jaws in the anterior posterior dimensions. But unfortunately, there was not that many patients who were actually cured of their sleep apnea after surgery. Are we okay with the sound, or should I turn off? Okay. So, a lot of them were having successful outcome, but there's still something wrong. And when I was this fellow at Stanford, we did these surgeries. I did about 50 or 60 of them that year. And I was responsible for taking care of them. I had to do their pre-op and then, answer their questions when they were done with the surgery. And it was just too often that we would do the surgery, we would do these huge advancements, pulling the maxilla and the mandible forward, doing the genotubical advancement, maybe not quite to the same level of perfection that we have now with Dr. Haney and Dr. Movahead, but still moving things forward. But these patients would still have airway issues. So this is a patient who we took to the OR, widened the airway, but no improvement. And the reason was that the tongue, as we can see in these diagrams, is still blocking the airway. So even though I move the jaws forward, the tongue sits back. And so that's where I got interested in myofunctional disorders. And so what I learned is it's not moving the jaws forward is really important. But there's one thing that's also very, very important as an adjunct to that, and that's the tongue. Because these patients often have a very weak and low tone tongue.
Open your mouth wide. Stick out your tongue.
So this is a patient who had a tongue crack procedure for me, and you can see that her tongue is just so weak. She can barely hold up her tongue and jaw, sticking it out of her mouth. Okay? And you can only imagine this is what she's like while she's awake. What's happening when she's lying flat? What's happening as she's going from light sleep to deep sleep? All the muscles of the body relaxing, the tongue is relaxing, the tongue is going to flop back, and it's going to obstruct. Let's do that one more time.
Lift up your tongue.
So she's able to lift up.
Open your mouth wide. Stick out your tongue.
Look at how much it quivers. Look at all that shaking, and look at all the compensation she has in her jaw just to hold up her tongue. And so what happens is that when the tongue is low in tone, the tongue will fall back and contribute to the problem with sleep disorder breathing. Let's learn a little bit more about that.
I suffer from this thing called sleep apnea. Okay? If you don't know what sleep apnea is, just ask one of the nurses inside the building. They'll tell you. It's a form of snoring, only it's worse. It's worse than snoring. I choke when I sleep. And I'm loud. I'm so loud that I wake myself up. And you gotta see the way I sleep. It's disgusting. Like this is what I look like when I say ha. Ha. Who is it? Who's out there? I didn't know I had sleep apnea. My mom told me I had sleep apnea. I was asleep at her house about 6 years ago, sleeping in the guest room. Same way I always sleep, just like this. Ha. 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 And I woke up. My mom's at the foot of the bed like this. Oh my God, Jose. You're dying! Mom, I'm not dying, I'm snoring. Joseph, that is not snoring, you look like this. Joseph, you have to go to the doctor and get that checked out. I'm telling you, you're going to die and I don't want you to die, Joseph, because I'll die. I'm hard enough if you die. Oh my God, Mom, I'm not going to go to a doctor for snoring. How long are you watching? That's creepy. And I kicked her out. Get out of here. Get out of here, Mom. I'm sorry, Jose. I did not mean to startle you. It's just that I was walking to the kitchen and I heard a noise coming from the guest room. It sounded like someone was killing a bear. And I was like, I don't have a bear. So I opened the door and I noticed that it was just you, Joseph. Snoring. So I'm sorry. You don't have to go to a doctor. Just go to sleep. Go to sleep. And die.
So Joe Coy, he's a funny comedian. And we laugh. But what we're laughing about is the fact that this guy is choking on his tongue. And he's having sleep apnea. And so what we're seeing is that there's many different phenotypes of sleep apnea. Yes, there's a phenotype where you have a protruded maxilla, you have a protruded mandible. But a lot of the times it's also accompanied by some kind of problem with the functioning of the tongue. And so what we're seeing in these folks is that normally the tongue should be up against the roof of the mouth, suctioned up. In folks with sleep issues, the tongue sits low. And sometimes the tongue sits low because of the nasal obstruction problem. Really the only way to breathe through your mouth is by putting the tongue down. And other times the tongue is low because of the tongue tie issue. And so what we're saying is that the tongue has to remain high up on the palate to remain toned and to stay out of the airway. And if it falls down or assumes a low posterior position, then this can threaten the airway and you get the snoring and sleep issues that we're seeing in this patient example. And so for these issues, for these patients with a low tone, low posture tongue, we've learned that myofunctional therapy, which is a series of exercises for the tongue and facial muscles, can really help to rehabilitate the strength of the tongue and the posture of the tongue so it comes out of the airway. And it can be an incredible adjunct to other procedures or skeletal procedures that are widening the airway. And so in myofunctional therapy, the goals are to promote exclusive nasal breathing, to strengthen and tone the muscles of the tongue and orofacial complex, and to promote ideal resting oral posture. That means we want the lips together, the tongue on the roof of the mouth, and exclusive nasal breathing. I was introduced to this through a meta-analysis that I participated on by lead author Dr. Matt Camacho that showed that this kind of myofunctional therapy, these exercises to strengthen the face and the tongue, can reduce the acne-hypopnea index by 50% in adults and 62% in children, with improvements to daytime sleepiness and snoring, and is really effective for a wide range of patients with little to no side effects. And it also plays an important role in preventing relapse. We also learned that myofunctional therapy, this idea of getting the tongue up out of the throat to the roof of the mouth, can improve adherence to CPAP. Why is that? Well, when the tongue is low and blocking your airway, you can put all the pressure that you want, but it's not going to bypass that tongue. But if you can teach the patient and do exercises to get the tongue out of the throat, then maybe now CPAP can work. And there's also studies that show that myofunctional therapy can help patients from temporomandibular disorders, as we'll learn and explore a little bit more in this lecture. And so myofunctional therapy is a wonderful way of getting the tongue back out. But a lot of times what happens is that the tongue was lost in the first place because of a problem with tongue tie issues. And these tongue tie issues that we'll describe to you are a little bit different than the tongue tie issues for speech and swallowing. So for speech and swallowing, what ENTs and pediatricians and primary doctors are taught to look for are tongue ties according to the cough-free tongue measurement. And what this does is it assesses the length of the free tongue. So that's the tip of the tongue to the attachment, the frenulum attachment. And so it's considered to be a tongue tie if that measurement is less than 3 millimeters. It's considered severe if this measurement is 3 to 7. Considered moderate if it's 8 to 11, but if, like in this case that we're seeing, where the attachment is about 16 millimeters, this is considered to be clinically normal if you're talking about speech and swallow issues. And so this provides a dilemma for us, because in our practice with myofunctional therapy, getting the tongue up to the roof of the mouth, yes, there's no way you're going to do that with this, we all agree. But what if you have this 15 to 17 mild to normal? Well, these patients may not have speech and swallow issues, but I can tell you that there's no way they're going to get this tongue up to the roof of their mouth. And if they do get it up to the roof of their mouth, then they're going to have compensation patterns, because they're going to have to fight the floor of the mouth. And when they fight the floor of the mouth, they'll have to engage their neck, and these patients will present with pain issues, as we'll see in this lecture. And so what we have is that, yes, it's well established that tongue tie can cause swallow and speech issues, and you might see these patients in your practice early on, and they get addressed. But if it goes undiagnosed, what you get is you get a propensity for mouth breathing, because when the tongue is low, you're not going to be an exclusive nasal breather. And so when you have low tongue posture, you get mouth breathing issues, and as Patrick will talk about later, this sets you up for problems with nose and sinus issues, and then you get teeth grinding, snoring, and this sets you up for a phenotype that is more susceptible to sleep apnea later in life. So let's take a look at this girl. She's 6 years old, restless sleep, frequent nighttime awakenings, nightmare, anxiety, and social, emotional, behavioral issues. And I'm asked to assess for tongue tie. Okay? So you look at this, and someone might say that no, there's no tongue tie here. And so now we're taking it a step further, and that's what this lecture is about. So yes, the free tongue length is more than 60 millimeters, true. But what we're seeing is that she's not able to get up her tongue more than 50%. And if she does try to get it above 50% of mouth opening, she's lifting up the floor of mouth and she's engaging her whole neck to do that. Okay? And so she's compensating for a restriction in her tongue tie. So what we learned quickly is the structural definition, the free tongue length, is somewhat inadequate to assess for these more subtle forms of tongue tie that impact myofunctional disorders. And so with Dr. Audrey Yoon, we went through the entire literature and looked up every single way of measuring the tongue tie. And the one that we validated in 1,050 patients was the tongue range of motion ratio. And so what this does is it's assessing the function of the tongue. So what you do is you have your patient open up their mouth for maximal opening, and you take a measurement. And then you have them put their tongue right behind the incisor papilla, and you take a measurement in that case. So here we have about 38 millimeters of the tongue incisor papilla over a maximum opening of 50. That gives you a tongue range of motion of 76%. And so you want the tongue to go above 50% without compensations. And so what this functional definition asks is not only is there a tongue tie, that's important, but what's more important is can they get their tongue up to the roof of their mouth? And so what we have is if they can get the front of their tongue up 80%, this is considered to be grade 1 and it's ideal. It puts you in the top 10%. If it's between 50 and 80, that's average. That's what most population will need. If you're not able to get up more than 50% in these diagrams, you're considered to be a grade 3. And a lot of the sleep applications that we see fall in the grade 3 category. The ones that are very, very severe are grade 4. And these patients are not able to lift up any more than 25%. So let's take a look at a few case examples here. We have a father, and if you can see the tongue there, but he's lifting just about below 50%. So he would be considered what kind of grade tongue tie? 3. So just below 50% would set you at a 3. If it's below 25%, it puts you at a 4. So let's take a look at the video. This is other cases.
Guys, show your tongues. Who's the shortest thing in the
Open your mouth all the way. You lift up. A little closer. Lift up. So it's less than 5% ability to tip on either one. Lift up again. Open up the other way. And lift up. There it is. You see that one? Okay. And right here. Lift up. Lift up your tongue. These kids are gonna look at dad. And these kids got sent to me because they're having ADHD and sleep problems, and they can barely sit still. They can barely sit still because if they put their head up, they'll choke on their tongue. And every night when they're going to sleep, they're not able to sleep comfortably on their back. They have to sleep on their side. Their side gets tired. They come on their back. The tongue is trapped. They choke on their tongue like we saw in that video. They go on their other side. Now they're having sleep fragmentation issues. They're not getting that deep quality sleep. And they're waking up tired and jittery, high sympathetic tone, fight or flight. And they're told that they have issues with AP. And so when the tongues are this severe, we sometimes talk, when they're so tight, we look to make an improvement. But our ultimate goal is that they're able to get their whole tongue up to the roof of their mouth. 95% of the time you do that with one procedure. 5% of the time we need to have 2 procedures. So we'll take a look at these kids. We'll look at the grade 4 tongue tie, and let's assess which one has met our goal and which one needs a little bit more treatment.
So both boys after their procedure and healing have really been doing a lot better. They have a lot more mobility, they're sleeping better for sure, and just as ADHD is really calming down. Yeah, and they just seem like younger kids.
Can I see your tongue, boys? Guys, let's see yours. Let's see your tongue.
So now he's lifting up about less than 50%.
All right, Riley, let's see yours. Get your tongue up to the roof of the mouth. There we go. That's great.
Okay, so there's 2 boys there. The boy on the left, the younger one, is able to get his tongue up and suction easily, so he's considered to be effectively treated. The other child is only getting up about 50%, just about less. Significant improvement from 5% to 50%. You can already see ADHD symptoms coming down, but he needs a little bit more progress with that. Okay? So we'll just take a step back and appreciate the fact that the tongue plays a very important role as a scaffold for the maxillary arch. You want your tongue to be up against the roof of the palate, and that's going to help work as like a natural palate expander and help you to develop a nice broad U-shaped arch. But if you have a low tongue posture for whatever reason, even if whether you're mouth breathing due to nasal allergies or due to tongue-tie issues that's holding your tongue down, well, now the tongue can't work as a scaffold. It can't perform that function for maxillary expansion, and you get that dental crowding that is now going to require orthodontic and dental interventions to expand. And so this has been known for quite a long time. The literature for this area was low, and so with my colleague Dr. Arthur Yoon, we did a study to validate this finding.
We eat and speak with them, but our tongues may be even more important than we think. In a condition called onchoglossia, also known as tongue tie, the tongue is tethered more tightly than normal to the bottom of the mouth by the lingual frenulum. While this is usually considered relatively harmless, new work from dental and sleep experts at UCLA and Stanford suggests tongue mobility is critical for proper development of the jaw and facial tissues. In the study, researchers evaluated tongue mobility in 302 patients using the tongue range of motion ratio and the Kotlow-free tongue measurement. All measurements were performed in triplicate to ensure consistency and accuracy. Each participant also had dental casts made and x-rays taken to capture anatomical features of the teeth, mouth, and face. Most people had normal or only slightly diminished tongue ranges, although some had more severe restrictions. Reduced tongue mobility correlated with a smaller ratio between the inner canine width and the canine arch length, which may indicate underdevelopment of the upper jaw. Limited tongue movement was also linked to having longer soft tissues at the back and roof of the mouth. Longer soft palates are common in people with obstructive sleep apnea. It's possible that people with reduced tongue mobility may breathe with their mouths open more or swallow abnormally, which may help elongate the soft palate. The longer soft palate could also arise from reduced tension holding up the soft palate due to narrower maxilla. Contrary to previous suggestions, however, no association was found between ankyloglossia and position of the hyoid bone, a horseshoe-shaped bone in the neck that moves with swallowing, chewing, and breathing. The group also found no relationship between decreased tongue mobility and the classification of malocclusion, which 2 small studies previously reported. But the lack of evidence for these associations doesn't mean they don't exist. While this study is one of the largest of its kind overall, there were few volunteers with severely restricted tongue mobility or with abnormally aligned teeth, which may limit some of the findings. Nevertheless, the results do suggest the tongue plays an important role in development of the mouth and face, and if the tongue cannot move freely enough, people risk developing high-arched palates, a narrow upper jaw, and longer soft palates.
So while there was limitations to that study, what it did show is that folks with these grade 3 and 4 tongue ties, the ones that can't get their tongue up to the roof of the palate, are going to have the dental crowding and V-shaped maxillary arches. So now we have a good indication that if you're not able to get 50%, then we want to interact and intervene prophylactically, or if you're seeing that high arch V-shaped palate, maybe you also want to look for the tongue tie issue that precipitated to begin with. But now we're also going to go ahead and look for compensations in the tongue tie, because this child is able to get up the tongue up, but it's straining a lot, like we said, at the floor of mouth and the neck. So this is an example not of grade 3 or grade 4, but rather grade 3 compensating to grade 2 with strain in the floor of mouth and the cervical neck. And it's these compensating forms of tongue tie that are not only going to cause maybe dental issues and sleep issues, but are going to cause pain issues for patients. And so let's take a look at compensation forms of the tongue tie.
All right, good. Okay. And so stick out your gut for us. Lift up your tongue. Okay. Lift up the tongue to the front of your teeth. Okay. So you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of mouth down, where it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up her tongue, and you see the dimple right here. That's reflected inside the frenulum attachment point.
Okay, so this was a patient you're looking, why does this patient have sleep apnea? Yes, she's a little bit overweight, but but why are her indices so severe? Why does she have moderately severe sleep apnea? And so we identified the tongue tie. We put her through myofunctional therapy and frenuloplasty, and then we did another study about 5 months later, and we found that she had 65 to 80% improvements in her RDI, her AHI, and ODI, as well as time spent below 90%. We're working to write up these cases to provide evidence to the literature that yes, myofunctional therapy and tongue tie issues can help these patients, and it's one other thing to look for, especially when you can't find other causes for the symptoms in your patients. And again, the way that this works is that instead of having the tongue low, where it's blocking the airway, the tongue is being moved up and out of the airway. Okay? And so what we want is the natural resting position is the entire time suctioned up through the mouth. The tongue is suctioned up, you won't get the snoring, you have stabilization of the soft palate, basically the tongue is out of the airway. And if you look at an infant, that's exactly what you see. So here's a 5-year-old infant with naturally optimal tongue mobility. The tongue just floats up. So this is what we want for our patients after our procedure, then with therapy. We want the tongue just to go up naturally. So now we look at this lady, 59 years, snoring, neck and shoulder tension, teeth grinding, unrefreshing sleep, forward head posture, we're trying to get her airway from the tongue below, and fatigue. And what we see is, this is more than just a grade 3 or 4 tongue tie. What we have is another compensating form. What we're seeing is that to get her tongue up, she has to pull up the floor of the mouth. Okay? And if you just touch these patients, you just touch their floor of mouth, they'll jump from pain, just because there's so tension in that area, right underneath the floor of the mouth. And so what we're identifying is that, yes, the 3s and 4s are going to cause certain problems, you're going to hit in the butt, and that's that. But there's also another kind of tongue tie, and this is the compensation pattern. And the compensation patterns can go from anywhere from a grade 4 to a grade 3 to a 1, a grade 3 to a 2 or 1, or even a grade 2 to a grade 1. And it's causing issues because of the compensation patterns of floor of mouth elevation, cervical neck engagement, and as well as when they move their tongue, they might move it side to side. So we look at this patient, for example, okay? She's getting sharp headaches, poor sleep, anxiety, chronic cervical neck and shoulder tension. And this pain gets worse throughout the day. So she's coughing, she's eating, every function that she's having, she's not able to do with her tongue. So what she does is she engages her floor of mouth. Look at how much she's pulling up the subliminal glands here in her floor of mouth. Look at the engagement of the neck here. Every movement, every time she swallows, she has to bring her neck forward. You can see when she moves her tongue side to side, the whole entire jaw goes with it, from one side to the other. And here's another example of that. And lift up your tongue, and then here's the frenulum restriction. She's lifting up the floor of the mouth here. The floor of mouth should actually stay in the floor of the mouth here. Now lift up your tongue. So that's all the mobility she has really in her tongue. Let's take it off, without the light. Lift up your tongue. She really can't do it here. Lift up. So lift up your tongue in here. So right, so this should be here. Lift up, so she has a grade 4 compensating to grade 3 tongue tie, so it's pretty severe. Do you see that in yourself?
I do, but I always think mine's not that bad because I can stick my tongue out.
Right,
My
so
tongue
that's
can
it.
stick the tongue out at all.
So we talked about anterior tongue tie, but posterior tongue tie is when you get the back of the tongue up, and you cannot get the back of the tongue up at all.
Wow.
And that affects the way your face develops, and it can cause a lot of compensatory behavior reactions. And so what we're seeing is that a lot of times these kind of issues, yes, they can cause speech and swallowing issues, but moving a little bit forward, it can cause tightness in the neck, in the shoulders, underneath the floor of the mouth. It can be very tender. You can get headaches and neck and pain tension. You can just see it when they talk. You can just see all of these muscles kind of engaging in the whole face, being overused because they're trying to compensate for that tongue restriction. The analogy with my patients a lot of times, you're trying to lift something with your hands, but if your hands are tied, now you're going to engage your whole back and neck, and it's going to cause pain symptoms that are going to radiate to places that may seem unrelated. Let's see another example. So here we are. We're going to demonstrate in our lovely patient grade 4 compensating to grade 2 tongue tie.
So first of all, open up and lift up your mouth, lift up your tongue. So she's able to lift up all the way, but she's pulling up her floor of mouth and she's straining a lot with her neck. You can see all this tension in her neck just to lift up the tongue. This is because the tongue's relaxed now. It's physically tethered to the floor of the mouth, and she's not able to lift up her tongue with the intrinsic tongue muscles. So she has to use all these muscles in her neck and in her jaws, and this is contributing to her chronic jaw pains in this example. Thank you for sharing with us.
Okay, and so what we see is that these patients with these compensating forms of tongue tie, they may have myofascial referral pain. So they're not able to lift up the tongue, so they're overexerting their masseter muscles in order to, they're engaging their neck, their trapezius muscle, and then they can have a lot of tightness in the back of the head as well. And not all of these myofascial referral patterns of pain are not always due to tongue tie, but if you've already looked at other things, the skeletal issues, and it's just things aren't matching up, looking for a tongue tie may shed some light in these cases. And so here's a patient, chronic history of neck and back pain, tension, clenching, TMJ issues, forward head and shoulder posture, fatigue. A very common sign of these is that they're a side sleeper. Okay? Trouble sleeping on her back, mouth breathing, dry lips, dry mouth. And we see that when she lifts up her tongue, the floor of mouth elevates, and she has some mild asymmetries as well. And so they did infrared thermography, and we see this chronic myofascial pattern of pain. And here she is 1 month later, after her frenuloplasty procedure, much improved neck tension, shoulders feel looser, improved posture, better sleep, and no snoring. So what we're seeing is that the whole body is connected. If the tongue is off for whatever reason, then it's going to affect her posture all the way down. And the way that it's all connected is actually through the system of fascia. So fascia is connective tissue that covers every muscle in your body, and when you have a restriction in the fascia system due to a tongue tie holding you forward, you're kind of restricted in your ability to breathe and your ability to function. So imagine that you're wearing a suit jacket, but you're wearing one that's maybe 2 or 3 sizes smaller. What's that going to feel like when you're trying to breathe? What's that going to feel like when you're trying to function? You're going to be in a chronically compensated state. Because of these tightness in the myofascial lines. And so there are many different myofascial lines. The ones that we talk about most commonly for tongue tie issues is the deep front line. And so here the deep front line is demonstrated. And here's a great example. I thank Dr. Alan Sprinkle for sharing this with me. And it shows the deep front line. This is all fascia. And the fascia is carved out from the tongue into the diaphragm, all the way down to the legs and the feet. And this will become important to understand as we listen to some testimonials later on, and they try to explain to us that when they release their tongue tie, they're breathing better, they're able to stand taller, they're able to function better in Pilates and things like that. It starts to make sense. The reason it makes sense is that it's all connected.
So here, for the first time that I'm aware, we have the deep front line, or core line, at least a piece of it, a big piece of it, and a long piece of it. And we start with the flexor digitorum longus with a little quadratus plantae attached to it, the tendon, the tibialis posterior with some of its hand-like attachments for the arch, and of course the flexor hallucis longus. The tendons have been uncrossed here so that you see the muscles going straight into the deep posterior compartment that fills in. It's kind of rough here because this was right up against the interosseous membrane, and the surface is the tibia and fibula. This goes into the fascia clearly. This is hooked right into the fascia of the popliteus, and that crosses over the back of the knee capsule. We're including the capsule here, and would have been, except it got cut into the section, the continuity of the neurovascular bundle coming across the back of the knee here. What we have in here, opening the book of this septum, we see the septum and its continuity into the iliacus muscle. So we have the iliacus muscle here, the psoas muscle beside it, the nerve, and the blood vessel would be here also, except that got taken out, and the pectineus muscle. The pectineus muscle has a continuity with perhaps you can see it here, the psoas minor. The iliacus has a continuity as we come up here, the proximal portion, the medial portion, with the quadratus lumborum. That interfaces clearly without reference. We've taken, obviously, there's no ribs here. You can see the interface between the crura of the diaphragm, the root of the diaphragm anyway, and the quadratus lumborum. The actual crura of the diaphragm have been removed from the front of the spine so that you can see the interface between the psoas and the diaphragm. I'm holding the diaphragm out here so that you can see the domes, and there's no question of a connection between the psoas and the diaphragm. Now if we can just let this drop and move above, we see that the diaphragm is very clearly held to the pericardium of the heart, and the whole mediastinal tissues here, which we would have to dissect in detail to see, of the connection between the heart and the lungs. So we just say that this whole connective tissue of the mediastinum comes up into the visceral cylinder of the neck. The person you see here had a tracheotomy either just before or sometime before he died. And here we see the floor of the mouth, so beautifully dissected by Todd, so that we can see the genial hyon. And finally, this structure at the top is his tongue. So having the tongue as part of this deep front line, we would, if we pulled this back and looked in the front, see the anterior longitudinal ligament and the front of the spine, muscles of the longus colli. But we have really dissected out here the visceral component of the deep front line. The hyoid muscles in the front, the visceral cylinder of the esophagus and trachea, and we were able to take it with the tongue and the throat. And there you can see the tongue is the most forward thrusting muscle of the visceral self.
And so what we have with tongue tie is that the floor of the mouth,
either just before or sometime before he died.
That's the problem. The floor of the mouth goes with the tongue. So anytime you're lifting the tongue, you're putting a strain on the entire fascia system here, from the chest all the way down into the left. So keep that in mind as we see some testimonials from patients. Just listen to what they're saying, and it all starts to become clear. So these folks who have the tongue tied to the floor of the mouth are lifting up and pulling on this entire fascia system with every movement that they make with their tongue, with every swallow, with every word that they utter. So here's a patient, 59 years old, long history of headaches, chronic sinus infections, forward head posture, cervical neck discomfort. She had an incomplete frenectomy, and that's going to be a key. So it's not only about separating the front of the tongue, it's really about separating the entire tongue from the floor of the mouth. Had maxillary expansion that helped a lot of things, but it just wasn't complete enough. And so when we look at her, she has a grade 2 kind of tongue tie. Okay? So this isn't the grade 3s and the 4s that we already know are going to cause problems. What we see in her case is that she has to engage her neck in order to lift it, and she has to lift up her floor of the mouth. And here she is 1 month later.
Hi, my name is Katerina Woodish, and my father's really tongue-tied, can't use his tongue at all, and I had a frenectomy when I was 7 because I was tongue-tied, and it didn't make much difference. My tongue looked sort of normal, but I've had really bad headaches my whole life. I have scoliosis, a lot of jaw tension, a lot of problems sleeping, and I had been told that perhaps I should go see an oral myofascial specialist, but I hadn't done that. I actually had to do a palate expansion because I had such bad sinus infections all the time, and I didn't want to do sinus surgery. And the palate expansion helped, and it helped the headaches somewhat, but not entirely. It got rid of the sinus infections, but I still have a very small palate. And eventually after that, I decided I would go see Joy, and I would, Joy Goldberg, and I would go have an evaluation. And she suggested right away when she saw how I was swallowing that many of my issues, including the not sleeping, including the constant headaches and the TMJ, might really change if I had a deeper frenectomy, that my adhesions, I don't know what you call them, were deeper in, were submucosal, and that they had not been disconnected in the first surgery. So I came to see Dr. Zaghi, and he agreed that this would make a big difference. And I had a tremendously forward neck when I came to see him. I was sort of like this all the time, and lots of tension all the time in the jaw, the back of the head, constant headaches. And the experience of the surgery was really amazing for me because I was scared of it because I had this botched one when I was 7. And Dr. Zaghi and his assistant were incredibly present and kind and informative, so that it wasn't so scary to do. The actual procedure was not painful or difficult really at all, but what amazed me during it was I had a need to go pretty deep to cut the cords. So what was amazing to me was that the first layer of cords, I didn't feel much, and I thought, oh, I'm going to be the one person this doesn't really change. And then the second layer, I started to feel this opening in the back of my neck, in particular that connects the spine. But the third layer, when he clipped them, it was like everything in my head and back opened up. And so now you can see that the way that I hold myself is completely different. This would have been impossible before the surgery. So in 1 second, there was this feeling of, oh, everything opened up. The pressure in my jaw is gone. The pressure in the back of my head is gone. All kinds of possibilities are opening up. I've had a little bit of a dance with my scoliosis because once things started to revise themselves, my dowager's thumb, which I had a really big one, gone in 1 second flat, but now the rest of my spine has to adjust to that. So I've had a couple of weeks where things keep coming and going and they're not necessarily so comfortable. However, I seem to be coming to the end of that already, so it's only been a month since my surgery. And mostly just what I feel is this tremendous expansion and a lightness in my head, neck, and jaw that I couldn't have imagined before. When it happened, I thought, oh, this is what normal people feel like. This is how easy it can be to be in the world. And the fascinating thing, because I work with people's emotions, I'm a somatic therapist, is to notice in myself how from the second that those last cords were clipped, there's a sense of ease in the world for me that wasn't there before. I'm not taking anything quite as seriously. I just have a fluidity and a sense of balance that I didn't have when I was always like this. So now there's so much possibility opening up. So I'm so grateful I've had this surgery. I wish I'd had this deeper one when I was 7 and didn't have to have this long process. So I would, to any parent who has a child, if your child is struggling with headaches or sleep problems and you know that there's some degree of tongue tightness there, if you could gift a child with what has just happened for me at the age of almost 60, if you could give it to a young one, it would be pretty amazing to not spend your life struggling with this tension. And those of us who have spent our life struggling with this tension, to us it's normal. We don't even know there's another possibility. But to find this other possibility now is really, I don't have words for it. I'm so grateful for it. And if you have a child who might have this issue, the surgery is minimal in comparison to the gift you could give them. So I would strongly suggest it.
So as she's talking about her tongue scoliosis, and we've seen that picture of the fascia, it's starting to make sense that if you're kind of constrained here, you're coming forward to your jaw, then it's going to tie you up. And if you just release that, these patients can have expansion. And so, I was really thrilled to hear this. I sent it to one of my mentors, the president of the Sleep Surgery Society, and he wrote this letter to me. He says, Soroush, I will honestly say I think you're better than what this one patient testimony would suggest. Anecdotal evidence like this can form the basis of scientific evaluation, but in and of itself is pretty useless. Go ahead and find a better evidence basis, higher quality science than what you give. And so, it's kind of like, hey, you really have to listen to your patients, right? Like what's going on? But that's okay. Because these opinions and these case studies is where science begins. And so, we've taken it from a case report to a case study, and we're going to show you how we've evolved it with our research. So let's just hear a couple more case studies, and then we'll show you our research.
Okay, so this is Nadia. Nadia's an occupational therapist. So Nadia just got her tongue done, an hour ago or something. And can you tell the doctors and the speech pathologists and occupational therapists and everybody in the class, what did you notice happened different?
Well, to begin with, when he started clipping, I felt that, I had this tension here on my neck, and all of a sudden, I could move my neck, better, more range of motion on my neck. And as he kept on clipping, the whole thing, it's amazing. It feels like there were like strings attached to somewhere, and they got released. And even I was telling Joy that I was parking my car, and I could turn my head to do a 3-point, and park. And before I had to basically lift myself and look to give me more.
Wow.
So it's very powerful.
And also what you said about her breathing.
My breathing. And before I had to I felt like I had to pull here to open my chest. Now I'm like relaxed and it just goes in. The air just goes in. It's amazing. And I just had that.
And then there was someone who heard me speak and wanted to experience it for herself, so she came in.
So I've been a member of the IAM for many years, and I've been following the whole line of discussion about tongue-tie. And I was once told that I was about 50% opening, so I thought, oh, am I not? I don't know, but the more I paid attention and the more I heard about it, and I learned that the tongue-tie is related to all the muscles up in your neck and your shoulders, and I thought, oh, wait a minute. I get it, because I have chronic headache, not chronic, I have chronic tension in my neck and my shoulders. And then I saw this surgery, and I saw it release, and I could see the relief. I could see every person who did that seemed to make this kind of like, and as you just did it for me, you did at least 3 clicks in, I think. And what I felt was, release here first, and then I can feel release and release, and I can breathe more. It just feels like the deepest breath I've ever taken. So, yeah, it feels pretty amazing.
Good time to be limited.
Okay, that's hard.
Oh, yeah. Okay. I got referred to Virginia from my craniofacial therapist, and she wasn't sure I actually had an issue, but she's like, you should go see Virginia.
Well, she knew you had all of the tension in your neck and your shoulders, and that it was unresolvable, that she had to keep adjusting over and over and over.
Yeah, I basically I joke about it, I'm on maintenance with the craniofacial therapist. I go to see her every other week, and I've been doing this for 7 years. But I'm getting better. I was getting better, but she's like, go see Virginia. I'm going to see Virginia. She's like, you got a tongue tie. You need to go see Zaghi, but let's start you because you have to strengthen your tongue before you have the work done. So I do the work.
Which was very hard work because she was so tender that she was getting jaw issues and
neck
problems.
TMJ, tons of tension. So obviously mine was so bad that I had to have it done in 2 stages. I've already had the first done, and the release was so incredible because it took away, in fact, you can still see when I do this, you can see this pulling. Before it was all wetted, and it took it away. The release was it took my body at least a week to get used to it. In fact, the next week, I kept forgetting what day it was. It was so disorienting to me, but it was in a good way. It was like I was on Hawaii. It was the same feeling that I get when I'm in Hawaii, where I forget what day it is. And my body felt the release. In fact, about an hour after I had the procedure done, I started crying, and it wasn't that I was unhappy. It was like I was happy. It felt like this huge release and tension had been let go of my body. It was fabulous. I mean, it was like I will classify that there's a few things I've done in my life. This is one of the best things I've ever done for my health. Easy. Yeah.
And the difference in therapy.
Yeah, and so you can imagine that you're always tight. You're wearing this jacket that's just way too tight for you. And it gets released, and you didn't even know life could be this way. And so, I've shown you four cases, and so this is the case series. And so you always want to be skeptical when it's just one case, or when it's a couple of cases, but I took the recommendation of that mentor who said go and do a more comprehensive study. And so now it's not 1, 2, 3, or 4 cases, but over 350, okay? Validating indication of this tongue tie release for mouth breathing, sort breathing, and craniofacial pain. This will be released later this year. And so it shows that we have about a 91% satisfaction rate and an 86% quality improvement of life. A lot of patients improve, about 90% of patients noticed the change. 96% had improved tongue mobility, 73% improvement of snoring, 78% improvement to pain, sleep improvements of 80%, nasal breathing improvements of 78%, swallowing improvements, as well as clenching and grinding. So it's really, really promising kind of data that's coming out. And it shows us one of two things. First of all, that this can work, that there's evidence behind it, but also that it's not for everyone. And that you have to really choose your patients carefully. So about 14% of patients didn't improve, which suggests to us that we maybe could have done a better job of identifying the patients that would benefit from this. And through the experience, we kind of developed that. And so we know that it's not only about the tongue tie, you have to have room in your space for your tongue. And so the patients that do the best are those where space has already been created, but the tongue is still stuck down. If there's not enough space in the jaws for the tongue, releasing the tongue tie doesn't do much, because even though it's free, it still has nowhere to go. Work in an interdisciplinary fashion in order to most effectively treat these patients. And so now we're looking at level 3 studies in retrospective. The next step would be to do prospective studies. So we talked about why we do it. And so now for the rest of the talk, I'll just start talking about how. How do we actually get these results? And so the first thing is to restore mobility. And so when I do these procedures, yes, we excise the prior scar tissue or frenulum, but our technique is a little bit more involved in that we actually go into the genioglossus muscle. And so this is what distinguishes the functional frenuloplasty from frenectomy. Frenectomy, yeah, you can do with a little laser, just a little bit tip there, but if you use a laser or dissect into the genioglossus muscle with any form of cautery, it can cause that tissue to contract, which is opposite of what we want. So when we're doing these procedures, if you're going to go deeper to get those posterior ties, I'll demonstrate to you, you really want to minimize scarring due to excessive dissection or indiscriminate use of cautery. You want the tissue to release itself, and you'll see in some of the examples that we've done. We like to use sutures for primary tension healing. Secondary tension healing causes scarring. The scarring is just going to retract it back down. Finally, it's so important to use myofunctional therapy because, as you'll see, we let the tongue and the tissues release themselves. This doesn't work if the tongue is flaccid. The tissues aren't going to separate. You really have to stretch that fascia, pulling down and pulling up. Down with your breath and up by pulling your tongue. That's how you're going to get the release. And then we recommend mouth washes to gently brush the tissue. Take it easy for a couple of days and then resume the postoperative therapy. What we're focusing on is the fact that you have the intrinsic tongue muscles, supralateral, transverse, vertical. Those are not covered in the surgery. The surgery focuses on separating the tongue from the genioglossus muscle. The genioglossus muscle has several branches. It has an inferior branch that goes from the chin down to the hyoid. It has a middle branch that passes backwards to the base of the tongue. And then it has a superior branch that goes under the surface of the tongue to the apex of the tongue. And it's these superior branches of the genioglossus muscle that are the target of the release in these procedures that we're doing. So let's demonstrate to you what we have here. And so what we have is a patient who has undergone expansion procedures. And so he has a compensation form of tongue tie, okay? So I'm showing you this case to show you one of the more advanced cases. Don't recommend doing this for everybody, but it's just to show you what's possible, okay? So this is an entirely submucosal restriction. He's getting his tongue up all the way, so it's actually a grade 1, okay? But let's just take a look at what happens. And his problem is that he can't get up the back of the tongue. So I clamp the tissue, the frenum, just the anterior mucosal part to start. Inferiorly as well as superiorly. And you can see that there's something that's holding down the tongue right here. It's pulling down, posterior, you can't quite see it. It's pulling down the tongue, it's pulling up the floor of the mouth. Median lingual septum, which runs between the two heads of the genioglossus muscle. And that muscle that we're looking there, those are the superior branches of the genioglossus muscle. And that's where the dissection happens for these posterior tongue-pie releases of the partial genioglossus. This procedure completes the sternotomy incision, frenectomy, removing the frenum tissue. And this is the limit in most dissections that are performed, okay? So that's where you stop in the traditional technique, okay? So now for this more advanced technique, we go a little bit deeper and watch what happens here. So these genioglossus muscles are targeted. We have them hold a cave, and we look for sources of tension. And I can observe that those genioglossus muscles are holding down the tongue. So we cut into it. Clamp. So this procedure is going to release the floor of mouth, the fascia going down, and the tongue going up. So we're only releasing the restricted muscle fibers. We're using a lot of blunt dissection to let the tissues release. And already you're seeing more lift of the tongue. The floor of mouth is settled in down. Okay. But they still look restricted. Again, the superior branch of the genioglossus muscle. And it's right behind it that you have the lingual vein, behind that lingual artery. Lingual nerve runs laterally to this, dissecting out those muscle fibers. Now watch what happens at this clamp tissue. Just a small clamp, and the tissue releases itself. See the tongue is getting up more easily, and the floor mouth is settling down. This releases. And there's minimal bleeding because the tissues have been prepared for myofunctional therapy. If tissues have not been prepared, the muscles aren't going to release like that. If he's helping me during the procedure, he's pulling his tongue up, and all this fascia is pulling the rest down, that's how you're getting that elongation release. If they don't have the myofunctional therapy, just cut into it, nothing's going anywhere, it's just going to stick back together. So you got to go down and up. This is where fascia therapy becomes helpful because fascia therapy helps the neck come down, myofunctional therapy helps the tongue go up, and that's how you're going to get that effect of release of the floor mouth from the tongue. So I'll fast forward this and go a little bit more. And this releases. video is online on my website if you guys want to see, as well as others. And then so we complete the procedure by putting stitches in. Then we do something like this, and then folks in the audience are like, did we do the right thing? And that's what we ask ourselves. We like to follow them up at 1 week, 2 weeks, 16 weeks. And so this patient wrote me an email to let me know that the experience was incredible. This very patient that we just saw. Truly one of the most profound experiences of his life. Just a few of the things that he's noticed. Sleep has drastically improved. Why did sleep improve? Because now he's getting his tongue up to the roof of the mouth, out of the back of his tongue. He's able to stay continuously in that deep sleep. He's dreaming again. That means that he's achieving REM sleep. REM sleep is that deep sleep in which you dream. All your muscles in your body are paralyzed. If you have a tongue-based obstruction issue, you're interfering with that REM sleep. What was interesting to me is that it's much easier to move air through the nasal cavities. Now, why is that? You can try it. Go ahead and suction up your tongue to the roof of the mouth. Try to breathe from your mouth. You won't be able to do it. The only way to get an exclusive nasal breathing is your tongue up to the roof of your mouth. When we do this procedure, we're releasing the genioglossus muscle that holds the tongue down, and it's an emphasis on the styloglossus muscle. So this tongue is suctioned up. They can't help but breathe through their nose, and it's much decreased nasal resistance. So when there's less resistance to nasal breathing, you're not seeing that collapse. You can avoid a lot of surgeries and procedures like that. Not only that, but he describes that his top teeth, for the first time in 20 years, come forward further than my bottom teeth. So he finally he's making progress with his orthodontic work. He's no longer feeling restricted because of that tongue tie was holding it forward. So here he is at 14 weeks post-op. And then people ask me, when do you know when to stop? And so here's a case, and we'll show you just that. So 28, grade 3 compensated in grade 2. And I think you guys can see in this example here that he's lifting up the floor of the mouth. And that's the key sign for the compensation. They'll lift up the floor of the mouth, and they'll swing their jaw side to side, and they'll engage their neck. They'll be very tender over there. That's how you know you have a good candidate. So we do the procedure, and you can see how things change. So this is what his swallow looks like after.
Good. And show your key again.
Just goes up.
You swallow for me. How does the swallow feel?
Just natural.
So much easier, right?
Oh, it's like effortless. Insane. So in order to have that natural palatal swallow, a lot of times people have to compensate. They're pulling up on their neck, pulling up on their whole body, and you can see them kind of jet their head forward and trying to swallow. So when they release this, it's just so much easier. It just kind of works. We'll see that one more time.
Good. And show your key again. And swallow for me. How does the swallow feel?
Just natural.
So much easier, right?
Oh, it's like effortless. Insane. All right. And so we'll show you another case how we do it in the trial. You don't always have to go that deep.
Sure.
So we'll show you the key part. So here, plant.
Very good. Swallow for me.
Have him hold the tongue up.
Lift up your tongue, lift up your tongue. Great. Very good.
So that's the connectomy part. So there's a little bit of median lingual septum, and kids don't have to go as deep into the muscle because there's not as much restrictions there. It hasn't been there for that long. So the tissue will let it flush. Just one more piece more.
Okay, very good.
Just this little piece of median lingual septum fascia right here.
No feeling?
That's going to be the key right there. Release the tissue. You guys can see over the tongue goes up. There's that little bit more pieces of that. And now the issue is that if you go in there with a laser or something like that, you're going to cause more fibrosis, which is why they advise you to use this technique and not go into the muscle to stay right above the fascia. So if you're going to do that, go ahead. There's just a little bit more that you can get with your scissors. You can stay free and clear release. Of course, it's only going to release if you've done myofunctional therapy separated. Otherwise, it's not going to release. It's just going to sit there and you're going to be disappointed. So there's maybe a little bit more that I go after. It's a little bit restricted there, we'll see. Okay, so going a little bit more. And then stitches in. The stitches help maintain that. You don't want it to scar back in. This video is also available on the website if you guys want to see it. So this reinforces the importance of myofunctional therapy. You gotta make the tongue strong enough to stay up. Okay? Most people who have this issue won't be able to get up their tongue, and if they do, they're engaging their core mouth and their neck. So we have them do a series of exercises that starts with things like the tick-tock, tick-tock, tick-tock. We graduate them to click. And then we have them suction up their tongue. They may suction up initially, using the whole neck, and we have them look in a mirror, make sure they're not using their neck, down, sideways down, only get the tongue up, and we have them straighten the tongue side to side, making sure they're not swinging their jaw, go back and forth. So the therapist works on an individualized plan so that tongue is ready. So on the day of surgery, you're having a nice, strong tongue that's going to help you with the surgery rather than getting in your way. That's why the preoperative therapy is so important. It's also really important postoperatively because you have to keep the tongue separated from the floor of the mouth, otherwise you'll get a reattachment.
Lift up your tongue for me. Lift it up all the way like you did before. See how the floor of mouth comes up? And a lot of patients who are highly compliant with their exercises, they try so hard that the floor of mouth comes up. When the floor of mouth comes up in the postoperative period, it's not good for the recovery because we want to separate the tongue from the floor of mouth. So what we do is we say we put a bite block in it, chew on the bite block, and now lift up your tongue to the front of your teeth, bring it to the front of your teeth. There it is. And back, take it back. There it is. And show me your click. Good. And we have the patients take a look in the mirror to make sure that they're not lifting up the floor of the mouth. Up to the front of your teeth. Yeah, just gentle like that. Exactly. That's the kind of stretch we want to see after our cranioplasty procedures. We don't want to see make your floor of mouth go up. Yeah. Yeah, so we don't want to see this. This is going to shorten the tongue. This is what we want to see. Okay. Absolutely.
So be gentle on that.
Yeah. And it takes about 3 weeks for that contraction period. So here it is 1 week post-op. He's doing exercises very nicely, very nice suction. And we remind the patients that they want to use their tongue to do exercises, not the floor mat. That's the whole key. So here's a husband and wife. Okay? A cute couple. They're both doing myofunctional therapy. Okay? One's seeing progress, one's doing it correctly, and one's not. Who do you think's doing it correctly here? The one on the right. One on the right is separating the tongue from the floor mouth, and this tongue is ready for release. You guys see that it's restricted? Okay. The one on the right, left, no, right? So if you're going to go in and you release him, you will not get a good result. You'll get scarring, and it won't work. So that's why we're trying to educate people to be aware of these things. You release it, what's going to happen? Floor mouth is going to go down, tongue is going to go up. You're going to have expansion in the chest, all the way down into the legs. She's going to say she came back from her yoga class, and now she's flexible over. Her knees feel better, her toes feel better. She's been really nice. So the analogy is that if you do no therapy, you're not going to be able to separate the tongue from the floor of the mouth. That's the first thing. If you do good therapy, you're effectively releasing the tongue from the floor of the mouth. You're getting a really nice stretch and elongation at the beginning period. If you do maladaptive therapy, what you're doing is you're elevating the floor of the mouth, you're engaging your neck. It's as if you've almost done no therapy. The next thing we talk about with patients is the process of wound healing. So as they're going through this, it can be painful for the first 3 to 5 days. That's a period of inflammation. After the inflammation subsides, you get granulation tissue, healing tissue, and that's followed by contraction. So the contraction happens from 3 to 30 days. You know, usually for the first week, patients will feel so loose, everything's great. And then starting at 1 week, things start to pull in. Okay? That's why it's so important to do myofunctional therapy, maybe have some body work done, massage, physical therapy, whatever it is, so that you're fighting that contraction period. You want to keep it open. After about a month, and things stay where they are, and they tend to loosen up for 2 to 6 months of the year. So when we see patients, we're doing a study to validate this as well, the wound healing. What we see is that after 1 week they're doing better, but by 1 month they're doing worse, and then after 9 months they do better again. And so that's really important. We're going to be publishing these studies the next 1 or 2 years to get on that. So risks of surgery, you can have pain or soreness. In our study of 350 patients, 45% of patients reported pain. 55 didn't have pain, 45% did have pain. Those who did have pain, it was pretty severe. We rated it as a 6 plus or minus 2 in severity. It lasted for 3 plus or minus 2 days. And we manage that with Tylenol, ibuprofen, and if needed, we give narcotic medication. It can be very sore and swelling. It always gets better. It always breaks by the 5th day. The other complications are bleeding or bruising. So 12% of patients had any bleeding. Among those, 7% resolved within 3 hours. 3% lasted for about a day, and 2% resolved within 2 days. Other complications we see from this procedure are numbness in the tongue tip. Numbness in the tongue tip occurs in 4.86% of cases. 2% of patients have numbness that resolves within 2 weeks. 1% has numbness that resolves within 2 months. 1.4% has numbness that lasts for 2 to 6 months. 1 patient had numbness beyond 1 year. Numbness happens, so the nerve runs laterally and comes to the middle. If you get really close to the tongue tip, you can get numbness in that area. The 1 patient who had numbness for 1 year was rubbing up her tongue against an appliance at her lower teeth. She had a persistent tongue thrust. So really we tell patients they'll take anywhere from 2 to 6 months after removal of trauma for it to go. Other issues that are common are swelling, inflammation, mild wound infections, palliative initial potential scarring. The need for revision surgery in our case was about 4.56%. So 4.5% of patients improved, but they had better tremability, but there was something missing. They wanted a little bit more, so we did a second stage for those folks. And then the perhaps the most weakening thing is that 13.4% of patients they didn't improve. And so that tells us that we can be a little bit better in our patient selection. We've gotten better, and we'll have to share that with you guys. So just a little reminder of why we do it.
One of the things I noticed was my breathing I didn't even realize that I was struggling to breathe. It was just such a transition of feeling the breath going through my body compared to how I was before. Very obviously, I was extremely relaxed. I almost just want to take a nap. Tension that reduced in my face, my head, and I was breathing really good.
And it was a complete and total release of tension, of pain, and I feel comfortable and at ease in my own body and in my own skin in a way I never have before.
I couldn't be happier. I feel like I have more energy now, more awake. My eyes, it's easier to open my eyes.
I had this tension here on my neck, and all of a sudden I could move my neck, better, more range of motion on my neck. And as he kept on clipping, the whole thing, it's amazing. It feels like there were strings attached to somewhere, and they got released.
My neck was tensing up. I'm to the point where I can see the tendons. Other people can see the tendons popping out of my neck, and that's completely gone. Basically, already I can tell that I can breathe so much easier. I can speak a lot easier. I feel like I'm more relaxed in general.
I'm so relieved to be finding answers and thankful for the work that the doctor is doing, and excited to get the word out because I feel like there's so many people who are suffering for nothing with the wrong diagnosis.
Mine was so bad that I had to have it done in 2 stages. I already had the first done, and the release was so incredible because it took away, in fact, you can still see when I do this, you can see this pulling. Before it was all way, and it took it away.
We came here as well to Dr. Zaghi because she would pop into her food all the time. I would take her at least 1 to 2 minutes for her to swallow each bite. But I realized on the first day of the surgery, she ate everything like so fast as if she had no problems at all. And that was like really fascinating for us to see because we haven't seen that for a long time. Actually, we've never seen her do that.
Every action for the last, as long as I can remember, 25 years, has required willpower. All of a sudden, post-surgery, bleeding, full of gauze, traveling, and having had no sleep the night before, I had an infusion of natural energy which has not gone away.
The release was so, it took my body at least a week to get used to it. In fact, the next week, I kept forgetting what day it was. It was so disorienting to me, but it was in a good way. It was like I was on Hawaii. It was the same feeling that I get when I'm in Hawaii, where I forget what day it is.
This is a 9-month follow-up, and we just got his sleep study results. It shows an apnea-hypopnea index of 2.3 events per hour, meaning that you no longer have sleep apnea. So, yay! Congratulations to you. No more need for oral appliance.
Okay.
Tell us some of your thoughts.
I'm just amazed with our work together and the surgery of my tongue. At my age to be cured of something, but yeah, I'm so excited. I'm just ecstatic.
And so, you just want to get the tongue out of the airway so that it can do. And I thank you guys for